Assalamu alaikum. First of all, I would like to thank Dr. Altaf Chima Saab that he gave me opportunity to present this teaching in front of you guys. I want to introduce first myself. I'm a Dr. Muhammad Ali Qureshi. I just graduated in 2004 from Allama Iqbal Medical College, and then after that I went to UK, did my graduation there, like basic medical training and then cardiology training, stayed there for more than 16 years, worked as a consultant for a few years, and then I came back like 2020, just before the COVID, and joined the Bahria Hospital. So since we have started this Umar Hospital, Dr. Umar brought me here and said, you won't be working anywhere else, just in this hospital. So it was a good opportunity to working here, and today I'm just presenting this case, basic interpretation of normal ECG in front of you guys. Okay, so this would be about 30 minutes presentation. I would try to explain about the different waves, intervals and segments of ECG, and also would like to develop a structured approach how to interpret a normal ECG and how to pick the abnormalities. You will be, I hope so, at the end of this presentation, you will be able to calculate the heart rate and determine the rhythm of the ECG. You will be able to recognize normal ECG, and I hope so you will understand at the end of this presentation the importance, the usefulness of ECG for a general practitioner, or you can say for other medics or surgeons and all this stuff. And last but not least, you will be able to identify common abnormalities of ECG. I want to tell you a joke, because when we are working in a specialized, different specialties, or working in different categories like gynae, surgery, or as a GP, sometimes we are more specialized in our work, we don't remember the ECG. Let me tell you that as an intervention cardiologist, when I was working like a couple of years ago with a professor of intervention cardiology, he used to say that I know only about the ECG. If it's ST elevation, get into the lab, I will do the intervention. If it is not ST elevation, I don't know about the ECG, I don't know about the patient, just go and manage on the CCU. So just it's a joke, but obviously we should know about everything. But
elevation is the most important
thing, because he knew that this is important, but other things I can manage, but only the ST elevation he can manage only. Gee, of course, if it's ongoing chest pain, you are right. So what is the ECG? The word ECG has been abbreviated from electrocardiogram, and actually it's a graphical representation. Word ECG has been abbreviated from electrocardiogram, and it's a graphical representation of a heart electrical activity which travels into the heart, and ECG identify that electrical activity from different angles, and we can get different waves in different leads. Actually, 12-lead ECG is a misnomer. Actually, when you do the ECG, you know that there are only 10 electrodes. There are 4 limb electrodes and 6 chest electrodes, but these electrodes take pictures or take activities from 12 different positions. You can see in this diagram there are 12 positions from where we can record the ECG. If you look on the history of the ECG, it started in 1942 when Mr. Mattiucci, who was an Italian physiologist and a doctor, who actually developed electrical activity or recorded the electrical activity from a frog. Later on, in 1887, a British physiologist named Waller, he recorded electrical activity, or you can say some form of ECG from a human heart. But main breakthrough was by the work of Einthoven, who was a Dutch doctor who built a electrogram or electrocardiogram machine. Actually, that was a 3-lead machine, and he named that electrical activity ECG, or it's called EKG, actually electrocardiography. He earned a Nobel Prize in 1924. After that, an American cardiologist named Mr. Wilson, who was a professor of cardiology in Michigan University, he developed central terminal, chest leads, and it was a big breakthrough, and it was later on adopted in 1938 by the American Heart Association as well. The last thing which was done a major thing which was done in ECG was from Dr. Goldberger. Again, he was an American cardiologist who developed augmented leads. So in 1954, American Heart Association make recommendations for standard 12-lead ECG. Until now, we are using the same pattern. So you can look into the evolution of ECG machines. You can see in 1887, Enthoven, he developed that ECG machine in which people used to sit with the two hands in a jar with the salt solution and 1 foot. And from electrode, they used to, record the electric activity. So it was a galvanometer. And you can say now this is advanced ECG, which we do most of the days nowadays. And the last advancement is that Apple Watch. This is, I think, good because a lot of people ask the question whether this is useful or not. Yes, I could say that it can work like a Holter monitor, just 3 leads only, but it can tell you about the atrial fibrillation, SVTs, and all this stuff. But it can't tell you about ST elevation, ischemia, or other abnormality like QT, intervals, and all that. But it's quite useful. If you look on the electrical conduction system of the heart, we can see, most of the people know that electrical activity generates from SA nodes. It goes from SA nodes to different parts of the atrium and then travel to the AV node. From the AV node, it gets distributed to ventricle via bundle of His, and obviously right and left bundle branch or fibers of Purkinje, and then it's depolarize all the heart, and we can get the electrical activity and contraction of the heart. If we look on the ECG, all of you know there's 4, 5, 6 components. One is the P wave, and then PR interval, QRS complex, ST segments, and T waves. P waves, okay, so P wave represent the atrial contraction, and PR interval represent the time taken from excitation from sinoatrial node to the AV node. It travels through the atrium and then AV node and bundle of His. As we know, QRS complex shows the ventricle contraction, and ventricular relaxation is represented by ST segment. We know that we record the ECG on a paper, on a special paper. And we all know that obviously we use a special paper for ECG, and there are small boxes and large boxes. Small box is about 1 millimeter in width and depth, and the large box is 5 millimeter in depth and width. There is we can see two axes. One is the time axis or x-axis, other is the amplitude like y-axis, and which anything goes along the x-axis is a time actually, we calculate. So as we know, the speed of ECG is important, because whenever you see a ECG, you should look on the speed, because if you change the speed, then you might say it's a Brady tachycardia wrongly. So it's 25 millimeter per second. It means that in 1 second, it moves like 25 millimeter, like it means 5 big boxes. And if we say that 1 large boxes is equal to 0.2 second, because 5 boxes are 1 second, so one large box would be 0.2, and small box would be, again, if you divide by 5, 0.04 second, or 4 millisecond, you can say 40 millisecond. So there are different ways to read a ECG. People say just do it in a 4 steps, 6 steps, or 7 steps, but I would like to say that it's a 10-step procedure. I know it looks like a little bit lengthy, but if you go through that step, you won't miss anything at all. So the first two steps are very important, I would say, because as you know, the patient detail, whether the patient is male, female, what's the ethnic group and all this stuff, because when we just go through the ECG, we know that different ethnic groups have a normal variant and all this stuff. And situation detail, rate, rhythm, axis, P wave, PR interval, and obviously segments, interval, acute interval, and T wave. These are 10 steps. We will go step by step along these 10 components. The patient detail, as I said, that we should know about what's the gender, sex, the age, and all this stuff, and whether the patient is in ER, ward, CCU, and ICU. It gives you a clue. If the patient is the CCU and has some abnormal ECG, like with the fast heart rate, you will be worried about more ventricular tachycardias if it's abroad and all this stuff. At least you should know about that before you see the ECG. It's a quite useful information. Situation detail, of course, that when the ECG was taken, like it was 2 days before, 3 days before, if it's a Q wave at least, and when was the chest pain and all this stuff, and other symptoms like whether you are doing any, serial ECG or not, whether it's required or not. And the most important thing is the symptoms of the patient, whether he has got a chest pain, palpitation, chest pain, palpitation, or other symptoms like dyspnea. So when you look on the rate on the ECG, as I told you before, that one small box is equal to 0.04 second, large box is equal to 0.2 second, and 5 large box is equal to 1 second. So to calculate the rate, we have to look the complexes, QRS complexes or R wave. So you can see from here, 5 boxes is equal to 1 second, and 300 boxes would be equal to the 60 seconds. So heart rate means how many complexes or how many contractions you get in 1 minute, like 60 seconds. So from here you can see easily that 300 large boxes is equal to 60 seconds. So if we measure the distance between the 2 R intervals, like 2 complexes, the boxes, if let's say if there are 3 boxes, we should divide with the 300, the answer would be 100. Okay? Sometimes it's difficult to look on the 2 large boxes, we can calculate the small boxes, it's easy. Because if there's a 2.5 large boxes, 2.5, 2.3 large boxes, it will be difficult. Then you can calculate like small boxes as well. Again, you have to multiply with the 5, because obviously 300 large boxes contain 1500 small boxes, and again time is same, 60 seconds. So the other method is, one is by the large boxes or small boxes, and other method is, as I said, the strip method. It's very easy method actually. Most of the people don't know about this method. When we see a ECG, it's a strip, it's a one strip. Let me assure you that it contains only 50 large boxes, like 10 seconds. So it's a 10-second recording of a heart. If we calculate the number of complexes in 10 seconds, we can multiply by the 6. So that would be the answer. It's quite easy. If you just make a habit of that, it's quite easy. So you can go either way. So this is the ECG. Can we do some practice, please? So you can see these are the, sorry, this is a pointer as well.
Five large boxes.
Oh, sorry. G. These are 5 large boxes, ठीक है, right? If you
300 से divide कर दें.
G, how much?
5 से divide करें.
How much the? 60. That's fine. Can we do the strip one, the strip method? This is one strip. This is a 10-second strip. Whatever we get the number of complexes, we can multiply with the 6. Can you calculate that, please? Anybody? But this is easy as well, but it's not like difficult. If you just calculate this one multiplied by 6, because 10, 9 or 10, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 9 or 10. 10 is, if you multiply it by 6, 60 आ जाए.
इसको सर जरा दोबारा एक्सप्लेन कर दें कि ये जो
जी आप इधर
कॉम्प्लेक्सेस हैं कितने हों और किस तरह करता है.
QRS कॉम्प्लेक्सेस कितने हों, क्या मतलब, मैंने आपको
अभी आपने शो किया है ना
जी
प्रीवियस स्लाइड में, अब देखिए ना उसमें QRS कॉम्प्लेक्स जो है
राइट
QR
जी आर आपने
जो इन बिटवीन द टू पीक्स
जी
QR कॉम्प्लेक्स
जी अगर आप इधर देखें 5 बॉक्सेस बिटवीन टू आवर्स के दरमियान डिवाइडेड बाय 300
वो तो
सिंपल है.
दूसरा मेथड जो आपने
दूसरा स्ट्रिप मेथड है, ये देखिए ये 50 बॉक्सेस है. दीज आर द लार्ज 50 बॉक्सेस. 50 बॉक्सेस मीन दिस इज 10 सेकेंड्स. 10 सेकेंड्स में जितनी भी कंट्रैक्शन होंगी अगर हम उनको मल्टीप्लाइड बाय 6 कर लेंगे तो 1 मिनट बन जाएगा. तो इट्स इजी एज वेल बिकॉज इट्स इंपॉर्टेंट वाइल वी आर लुकिंग ऑन द atrial fibrillation when it's irregular. That is quite useful when you are using atrial fibrillation. When the QRS complexes are irregular, especially in arrhythmia, different type of sinus arrhythmia and other arrhythmia. जी 6 से 10 मिनट्स की 10 सेकेंड्स की ये है ना स्ट्रिप. 50 लार्ज बॉक्सेस हैं. ठीक है, थैंक यू. You can look into that. If you look on the rhythm, whether we have to look rhythm is regular or irregular or it's irregular or regular, so we have to look that whether there's a P wave or there's no P wave. And we have to, especially sometimes it's difficult when it's a bradycardia, when it's very slow, then your eye can't judge properly whether there's a distance between 2R and R interval, because we have to look on the RR interval whether they are fixed in each complexes or different if you look on the strip. So if it's a bradycardia or tachycardia, we should use the paper method. Take a paper, just put up 2 or 3 dots in front of the complexes and then move forward. If it's going coinciding with a QRS complex, it means it's regular. If it's not coinciding, then obviously it's not regular. So if you look on this rhythm, so we have to look RR interval. As I said, the distance between 2R is equal in all complexes, in all strip. जी
ये चार बॉक्सेस हैं
जी
3 बॉक्सेस हैं.
roughly 100 हो गया. ठीक है ना. P wave is coming and there's the QRS complex, right? So this is normal sinus rhythm. If you look on this one, the second one, we can't see, obviously we can look on the rate 1, 2, 3, 4, 5, 6, isn't it? Yeah. 1, 2, 3, 4, 5. जी, there is no P wave here. जी, there is no P wave here, so it's a junctional rhythm with hidden P waves is coming some. This is abnormal rhythm, and this is the inverted P wave. P wave in lead 2 should not be inverted. This is the rhythm lead. It means it's coming from, not from the SA node, it's coming from somewhere else. Just to make it simple, if it's inverted in lead 2, it's not sinus, it's junctional rhythm with the P waves before QRS complex. And this again is junctional rhythm. Junctional rhythm means it's coming not from the SA node or not coming from the SA node. Either it's coming from the atrium, AV node or bundle of His, not from the ventricle.
P wave जो inverted है.
Right.
Signals are coming somewhere from the AV node or Purkinje fiber.
G, Purkinje fiber might be above from the atrium,
Right.
but in a different way, not in proper way because it's inverted. Yeah, ectopic force. Yeah, we are thinking about the ectopic force from the atrium. Ectopic हुआ ना? Sinus now. It is not originating from the SA node. It's not sinus or junction. Other than SA. Ectopic we just call when there is only 1 or 2 things coming up. If it's not like in a regular manner is coming, we call it a junctional rhythm until unless it's a narrow complex. If it's a broad complex, then it might be coming from the ventricle, and we can discuss about later on the idioventricular rate and all this stuff. So this is junctional rhythm with the P wave after QRS complex. So again, this is junctional rhythm. Okay. So this is the ECG. Could you please identify the rhythm? If you just, I would like you to just concentrate on RR interval. Are these RR interval, are they equal or different? Different. Are they irregular or they are in a regular pattern? So what could be that rhythm then? Atrial fibrillation is quite common, atrial fibrillation. So we can't see, other thing is a P wave. We can't see any organized P wave. Can you see any organized P wave?
जो नेगेटिव डिफ्लेक्शन जो है ये क्या शो कर रही है? आर वेव की है ये या
So yeah, Q waves है. Yeah, we call it R wave. Any complex, but don't worry about this whether it's a Q, S or R. It's a QRS complex. Some people call it R wave. Some people call it QRS complex. Up to you.
नेगेटिव है.
Yeah, this is something else. We can discuss about, but I'm just concentrating on the, yeah. There's a, you can say it's a poor progression of R wave, and these are the Q waves. I'm just trying to tell you about the rhythm here, isn't it? This rhythm. Yes, you pointed out very well. These are the Q waves. These are Q, negative deflection. Like old MI, and now his patient is having the atrial fibrillation as well. And we, other words, we can give poor progression of R wave. Because there is a S wave, is not coming any R wave until V4. There's a some G, P wave, there is no P wave at all. That's reason is atrial fibrillation.
किस किस्म का अरिथमिया है सर?
Atrial fibrillation, this is atrial fibrillation, AF. ठीक, irregular.
उसमें P wave इसमें भी नहीं होगी उसको.
G, if there is no P wave and interval is irregular, there is no regular interval, so that is the atrial fibrillation. Right. Absence of P wave, right? Next slide. Can you look on the, if you feel it's difficult, I can stop, I can just skip one, but if you feel it's interesting and all this stuff, then carry on.
इसमें भी जो है वो जो डिफ्लेक्शन है नेगेटिव का
Sorry. Yeah.
ये है तो regular है.
That's good, well done. And look on the P wave, we can't see any organized P wave, but you can see some sawtooth-like appearance. Yes, well done. You guys are becoming a physiologist. Flutter, atrial flutter.
P को उससे T से कैसे differentiate करते हैं?
P को, because P है नहीं, it's just आप देखिए sawtooth-like. जी साथ अंदर ही आ रही क्योंकि जी atrial flutter is like at the rate of 300 beats per minute. तो 300 अच्छा खासा रेट है 300. अगर आप देखें 300 में वन बिग बॉक्स उसी के अंदर जी दो बॉक्स है, एक बॉक्स होगा तो वो 300 ही हो जाएगा ना. तो
ये जो नेगेटिव डिफ्लेक्शन शो कर रहा है इसमें ये P
नहीं, ये अलग-अलग स्ट्रिप्स हैं. दीज आर द डिफरेंट.
सही है. फिर उसके बाद दोबारा जो है डिफ्लेक्शन है.
कौन सा, ये वाली आप कह रहे हैं? नहीं
ऊपर
पहले वाली पे नहीं, सब में आपको पता पॉजिटिव डिफ्लेक्शन आ रही है ना. आर वेव है
आर की तो ऊपर ही है
जी, टी वेव टी है ना.
अच्छा टी वेव.
ओहो सॉरी.
ये बताएं कि ये जो एट्रियल फ्लटर में एक्टोपिक फोकस होता है.
जी बिल्कुल एक्टॉप.
बस ये बात है.
जी
जी
एक्टॉपिक. राइट बिल्कुल एक्टॉपिक है जी. बिकॉज वी आर सेइंग arrhythmia is, we call the arrhythmia when it's not coming from the SA node. If anything is coming from the SA node, that is sinus tachycardia, sinus bradycardia. When it's not coming from the SA node, it's something else.
Here the rhythm is regular.
Here the rhythm is regular.
And heart rate is
एक स्ट्रिप है ना हमारी, उसमें 50 लार्ज बॉक्सेस होते हैं. इट मीन्स वन स्मॉल बॉक्स, जो 5 स्मॉल बॉक्स होते हैं वो 1 सेकेंड होता है. 50 बॉक्सेस कितने होंगे? 10 सेकेंड्स होंगे. तो वो 10 सेकेंड का हमारे पास टाइम पीरियड है. 10 सेकेंड में जितनी बीट्स आएंगी उसको मल्टीप्लाई अगर 6 से करेंगे तो वो पर मिनट बन जाएगा ना. हमने देखना हार्ट बीट मीन हाउ मेनी बीट्स आर इन 1 मिनट और 60 सेकेंड्स. अगर हमें पता हो कि 10 सेकेंड्स में इतनी बीट हैं तो आप 60 सेकेंड में उसको मल्टीप्लाई करना है ना. डू यू अंडरस्टैंड? ठीक है ना. लेट्स से पुट जी वो मैं अभी हम गो थ्रू करते हैं. ठीक. अच्छा जी, फर्स्ट आप देखिए इसमें रिदम जो है हमें लग रहा है रेगुलर है, नॉर्मल लग रहा है. ठीक है इसमें, लेकिन हमने पी वेव देखनी है. वी कांट सी एनी पी वेव. थोड़ा सा साटूथ लाइक अपीयरेंस आ रही है, थोड़ा सा आपको हेजी और इस तरह फ्लटरी सेंसेशन आ रही है. वह फील वाला फ्लटर, ये फ्लटर है. ठीक है, लेकिन ये नहीं टी वेव तो ये है टी वेव, लेकिन इसी के अंदर फ्लटर आ रहा है ना थोड़ा सा. ये एट्रियल फ्लटर है, ये फ्लटर वेव्स हैं इसके अंदर ही. पी वेव्स नहीं है. ठीक है. अब ये जी राइट, जो फ्लटर होता है वो हमेशा 300 पे रेट पे होता है. अब ये देखिए इसका हार्ट रेट कितना है, क्योंकि आप पहले भी कैलकुलेट कर रहे थे. यू वर डूइंग द 2 बॉक्सेस, सो 150 नो 150 No.
On the
300 divided by 2 is 150. So जी वो मैं बाद में हम उसको डिस्कस करते हैं. Just let me finish with the first one. We will go about the second, third, and fourth one. So obviously 150 is hearted. Flutter always goes on like 300, but obviously it's not every flutter wave is getting conducted through the AV node. It means this patient has a flutter with 2 into 1 block. So one impulse is not conducted, other impulse is getting conducted, because we know flutter is originated, or flutter waves comes at the 300 per minute.
Recorded rate is
150, yes.
But actually flutter comes at 300.
300, yeah. So it's a 2 into 1 block. So one is not getting conducted. So look at this one. It's not a really good one, but obviously you can see whether it's a regular or irregular. And tell me. And P wave, we can't see anything P wave as well, isn't it? So either you can call that is a flutter or atrial fibrillation or whatever you call, but regular. Here, let me tell you, this is how much is the rate? Just tell me about the rate.
150. इसमें भी round about 150 के ठीक है.
No. 3 boxes. It's 100.
100 हो गया.
100 हो गया.
ये बताएं कि leads कौन सी lead है उनकी वजह से?
ये lead 2 है. These are rhythm lead. Lead 2. Lead 2 is all rhythm leads, because we check the rhythm in lead 2, the limb lead 2, okay? So this is again, it's a flutter, but 3 into 1 block. Might be complex for you guys, and let me tell you about this one. Can you see any T wave, P wave, whether it's a regular or irregular?
इसमें P wave भी है और इसमें T wave भी है.
Regular है.
Again, it's a regular, that's good. And both P wave and T wave. And let me tell you now, this patient is having a treadmill. This person is having a treadmill. We have recorded while he was having a treadmill. So what's your answer about this rhythm? Sinus tachycardia, because he's running, yeah. And what's the heart rate here?
150.
Yeah. Yes, 150. Yeah, if somebody tells you patient is sitting and having 150, you will be surprised why he should have a sinus tachycardia 150. But if he's running and something else is doing and all this stuff, then you can say, okay, you will sinus tachycardia exercise से हुआ. ठीक है, और अब इस पे आ जाएं again. What about this one? Is the regular or irregular rhythm wise? Irregular. Irregular, isn't it? There is no specific pattern. It's irregular. And what about these waves, or can you see these again? It's a fluttery sensation.
They are all symmetrical. है तो सारी symmetry है इसमें.
जी.
उसमें ये है कि T wave R wave है.
T है या P wave?
ये P sawtooth appearance है ना थोड़ी सी T wave भी आनी flutter. This is again the flutter waves. Flutter with the variable block. It's not like 2 into 1, 3 into 1. This is a variable block. Some waves are getting conducted, some waves are not conducted. Some people call it AF, but it's a atrial flutter. Flutter with variable block.
सर ये एक ही लीड में डिफरेंट रीडिंग्स या डिजिटल रिकॉर्ड कैसे आ रहे हैं?
ये रिकॉर्ड कैसे है?
लीड एक ही है.
नहीं लीड ऑब्वियसली इट इज अ डिफरेंट पेशेंट. ये डिफरेंट पेशेंट है ना, डिफरेंट पेशेंट है. मैं तो जस्ट रिकॉर्डिंग के लिए जी वो ऑब्वियसली हाँ दैट्स गुड. या वो पीवीसी है जी, पेंटिकुलर टॉपिक्स. ठीक, तो क्योंकि अब सारी ECG इस तरह नहीं हो सकती. Think about now axis. Have you heard about the axis and also how to calculate? If you look on this cartoon, it would be quite easy to know about the axis. You know, heart always sits here, like here. This is apex. And if you look on the, the pattern of the leads, AVR is over there, is 150. And this is over AVL. I'm sorry because just due to time I can't see this one. Let me change whether I can. Next one, no. But anyways, let me tell you, this is our AVL lead, position of AVL. This is AVR, this is lead 1. This is lead 2 at 60 and on 90 is AVF. And lead 3 is at 120 positive. So if you're
limb leads है ना?
The only limb leads, because axis we can determine from the limb leads, not the chest leads. We look on the all 6 limb leads, but actually we just concentrate on 2 limb leads. One is lead 1 and other is AVF. Our normal cardiac axis is a yellow one, starting from negative 30 to positive 90. So this is the normal cardiac
सर augmented
axis.
जो leads हैं उनका क्या रोल है?
Augmented leads, just they know about the position, not like for the proper axis, but just different walls of the heart. When we go through the like ischemia, then they would be more helpful for the ischemia as well. Augmented leads, because they have a connection with the central leads as well as with the limb. These are the, you'd say these are the, not bipolar, these are unipolar, but it represent the both, like the horizontal as well as the vertical. Okay.
What is the importance of axis?
Axis, yeah, it's very important, because obviously in different diseases, we will go through the different diseases and we'll go through there. So if you look here, as I told you that if the heart is here, because all the electrical impulses will come from here to here. This is a electrical activity coming from here. If the lead is here, if it is within the 90 degree, it means it will project it as a positive. Because it's near to that lead. And again, it's near to this lead as well. If it's sitting like your axis is sitting here, because it's not away from one, if it goes away like from 90 degree away, like if something is here, and this lead will read it as a negative. If I say the heart is sitting here. If the heart is sitting here, this lead will take it as a positive, and this lead will take as positive as well. But if I say your heart is sitting here, so this will be negative because it's away from 90 degree, and this one read as a negative as well, is the extreme right axis deviation. If your heart is here, this is left axis deviation. If your heart is here, this lead will take it as a positive because it's within the 90 degree, but this lead is very far away from this axis, from heart, apex of the heart from here.
कार्डियोमेगाली में है?
जी, कार्डियोमेगाली, हाइपरट्रॉफीज, लेफ्ट बंडल ब्रांच ब्लॉक और बाकी हम देख लेते हैं, ठीक है. अगर हमारा हार्ट अगर इधर होगा, फर्स्ट कर ये हमारी जो अपेक्स है इज कम्स इन दिस वे लाइक ऑन द राइट एक्सिस, सो AVF lead will read is as positive, but lead 1 will be negative if the heart is here. So you can say up down, there's a different way. Look left each other, some people say for the left axis deviation, left each other, the lead 1 is positive but AVF is negative, so left each other, rejoin, join each other. So some people say like that, up down, and you can just look on this cartoon as well. It's just if you concentrate, if you remember this cartoon or this picture, you will never miss about the axis, right? So tell me about this ECGs, the A and B ECG axis. Concentrate on two leads only. One is AVF, other is lead 1.
Right.
Well done, yeah, that's good. What about this one? B, question B, ECG B. It's the normal. Okay, that's good. Now tell me about the causes of left axis deviation and right axis deviation. Left axis, I told you, this is the left axis. If the apex comes here, if the heart comes here, it's left axis. If heart comes here, move here, it's the right axis. So sometimes obviously it's normal as well. If you see the patient, like normal person who is having not normal, it's a patient having ascites or pregnancy, diaphragm would go up and the heart will move towards the left side, okay? Just on the top upper corner, left corner. And other is obviously LVH. In LVH, left anterior hemiblock, inferior myocardial infarction, hyperkalemia, and these are the different, causes of that. We can go into the detail because I'm just going to arrange a series of ECGs, but not just ECGs, about the cardiology diseases, because all the cardiology evolves around the ECGs, okay? The ECG is first and most important, and American Heart Association or ESC, like European Cardiac Society, they class one indication for ECG for any heart problem, like for hypertension, for other things. So ECG is very, very important. So P wave interval and P waves, we know that the P wave is generated when there is an atrial contraction, and PR interval is the distance from ventricle up to the ventricle contraction. You can see there, and it's very important to know about these. Yes. So one is, as we already have done that we should know about the P wave is coming or not, just to identify a rhythm problem. And other is whether P wave is associated with every complex. Like we saw in junctional tachycardia, there was no P wave, and then we just knew that it's not coming before the QRS complex. If it's coming after, or if inverted, it's not proper rhythm. And then P wave morphology is very important, whether it's a broad or not. You might have heard about the bifid and notched P wave, means more than 3 small boxes wide. So we call P mitral, and it's indicative of left atrial, hypertrophy, which is caused by mitral stenosis. That is most common, disease in Pakistan, rheumatic heart disease. And tall peaked P wave comes when there's a P pulmonale, when there's a pulmonary hypertension due to cor pulmonale or any other problem, or tricuspid stenosis or something else. You can see here, this is a P wave, and these are 2 just ECG complexes just to show P pulmonale, because it's quite high, more than 2 to 3 small boxes, and this is more wider, P mitral. Again, just might be more complex for you guys. We see P pulmonale in the lead 2 and P mitral in lead V1, just leads. It depends on the position where the left and right atrium are sitting. We can be looking on that. So next is P wave interval. We know the normal P wave interval, PR interval is about 0.12 to 0.2 seconds, like less than 5 small boxes or less than 1 big box. If PR interval is prolonged, of course, it's abnormal, and this indicates about the heart block we call first degree heart block. And we can obviously go through later on about these blocks. And short PR interval is very important again, because if there is an accessory pathway, it means that from sinoatrial junction, electrical activity is going through the atrium. It's not going through the AV node, it's going through some accessory pathway. Actually, AV node is very important. It's a speed breaker, because anything is coming very fast, it just slows it down, as we have seen in in atrial flutter, atrial fibrillation. Because in atrial fibrillation, in atrial flutter, heart rate goes like, atrial activity goes at 300. If this all get conducted, then your ventricle will contract at 300, and it will degenerate into ventricular fibrillation. That is dangerous. And the person can survive atrial fibrillation or flutter, but they can't survive ventricular fibrillation, as you know, if it's getting conducted. So that's the reason short PR interval or accessory pathway are the most dangerous thing which you could have. And PR depression sometimes happens in pericarditis as well. We can just look. Again, about the Q waves. You heard about like physiological normal Q waves, because sometimes there are normal Q waves in the left lateral leads. It could be normal, deeper could be normal in lead 3 and AVR. These are normal variant. And under normal circumstances, Q are not seen in any right-sided leads, V1 to V3. Okay. So to call it abnormal or pathological Q waves, the Q wave should be more than wider, like 1 millimeter more than 1 small box wider, or you can say 40 millisecond or 0.04 second, whatever you say. And it should not be deeper than 2 millimeter, like 2 small boxes. And if Q wave is more than 25% depth of the QRS complex, then you can call it abnormal. And the pathological Q waves are only due to current or prior, myocardial infarction. And this cartoon is very important, because some people say, why we call this QRS complex? Because it depends upon the axis. On the left leads, your ventricle is get depolarized from left to right. So it will be a negative deflection, because heart axis is here and impulses are going there. And the next is coming down, like into the septum. It will be a positive. right? Third thing is here, so it's going up again. D, you can see, C is going up there, is positive again because it's going up from here to here, from apex to going up into the posterior anterior wall of the left ventricle. So it would be positive, not positive, it's coming down because it's going opposite. And last one again is going up from here, so it will give you a S wave. It goes down and then come up, so it's called S wave. So just it's a normal pattern. How could we get this physiological Q waves? And obviously there's a different mechanism for pathological. It would be too complex, might be for this talk. So assessing Q waves and QRS complexes. If the QRS complex is broad, then it's abnormal. As I told you earlier, it should be less than 3 small boxes or 0.12 seconds. So these are the different causes for broad QRS complex. We know bundle branch block, right or left, hyperkalemia, pace rhythm. Some people look on the pace rhythm, they say, oh, might be a left bundle branch. Actually, it's not, because some spike is coming, or we should ask about the patient whether he has got pacemaker or not. Sometimes the advanced new pacemaker doesn't give you much deflection before the QRS complex. And obviously in WPW syndrome or Wolff-Parkinson-White syndrome, you could have a pre-excitation of broad QRS complex, ventricular rhythm and tricyclic antidepressant if you're taking, and there's a toxicity, you could get that as well. Could you please look on these 2 ECGs and tell me what's going on here? Just we can concentrate on the broadness of QRS complex and pattern. Can you see here? The QRS complex in both ECGs are broad. So this is a different pattern. One is the William, is a W pattern in V1 to V2, and there's an M pattern in V5, V6. So it's Williams. Negative deflection. There's no Q wave, but because we can see first deflection, we have to see if there's no first deflection, then you can say. But जी, ये S wave हम इसको कहेंगे ना, ठीक है ना, जो S है, R wave तो नहीं कह सकते, ये S wave है. ये
तो फिर उसके बाद तो QRS complex है सर.
जी, नहीं, S wave QRS complex का part है ना. Q is first, and then R is not available here, but this is S, and then obviously it's a T and all this stuff. Right. So just concentrate on that pattern. Is a left bundle branch block. As I said, we will be having another talk about the bundle branch blocks, first degree, second degree block, just to get some idea what's going on, why it's important QRS complex. If it's a broad, then it's abnormal. So again, the QRS complexes could be tall as well, like in left or right ventricular hypertrophy. If it's a tall, there's a one of the criteria, Murphy's criteria, is quite common. We can see we have to calculate the deep S wave. I said this is the S wave. Yes, you can say here these are the Q wave, but the QS you can say. So you have to calculate S wave in V1 or V2, whichever is the larger one, and then add into the R wave of V6 or V5. So if you add these two and it comes more than 35 mm, it means it's a hypertrophy, left ventricular hypertrophy. We'll talk about right ventricular hypertrophy later on. And QRS complexes could be small as well. So in pericardial effusion, you can say obviously there's fluid around the heart, so obviously it will not conduct it properly. Like in high BMI patient, those who have obese, you could have the same small QRS complex due to the fat deposition, emphysema, COPD, cardiomyopathy, or cardiac amyloidosis. So ST segments is again very important. It could be normal, depressed, or elevation. It's quite. If patient is having ischemia or any heart attack, so you have to look into these. If the patient comes with a chest pain, so if coming with a chest pain or symptom might be dyspnea with sweating, though you have to concentrate more on ST segments and T wave. So you can see here. If you get only ST elevation or depression only in one lead, it's not significant. It should be at least in 2 consecutive leads. Like if I say there's ST elevation in V1 and AVL, these are not 2 consecutive. V1 is a chest lead and AVL is a left leads, limb leads. It's not consecutive. If I say there's a ST elevation in AVL and lead 1. Yes, these are 2 left leads. So these are the consecutive leads. So either it should be ST elevation or depression should come in 2 consecutive leads, okay, like same with the geography. And it should be for the limb leads, because limbs are away, so it should be at least 1 millimeter, and chest is near to the, like heart is near to the chest, it should be 2 millimeter. So for limb leads, ST elevation or ST depression should, for pathological reasons, should be at least 1 millimeter or more. And for the chest lead, at least it should be 2 millimeter or more to be significant. But sometimes you can't say, because this patient is ongoing angina and having a heart attack, initially it might be 1 millimeter, later on if you do like after 10 minutes, it will be 2 millimeter, then 3 millimeter, 6 millimeter, 7, 8, 10 millimeters we have seen when patient come with the ST elevation MI. So as I said earlier that this ST elevation always indicates infarction, and depression is due to ischemia most of the time. Could be sometimes reciprocal changes or rate-related ischemia, but we can. Yes, yes. I will go through this. And there's a different pattern. Yes, sometimes you can get these. We will just talk about later on, because as I said, I will be having a talk on different, in myocardial infarction, pattern of the ECG, and now I'm going to talk about high takeoff. No, these are two different. Infarction is ischemia is patient is having a reduced blood supply towards the heart, and heart is like having less than 30 or 20% only blood supply is getting. But infarction happens when there's a complete blockage of the artery, and the myocardium does not get anything at all. So that is an infarction. Ischemia is reversible, and infarction obviously it could be reversible if it comes to my table quickly, like within a few hours time, and if I am able to open the artery, then it's reversible. Yes. So the other thing is high takeoff. Sometimes also people heard of early repolarization, high takeoff. This could be a normal in some individuals. These are the concave and different patterns for these as well. We can discuss about these things later on when we just do a lecture on ST elevations, myocardial infarctions, and all this stuff. But we should concentrate more on the, and again, pericarditis, you are right. In pericarditis, concave upward, not convex. In ST elevation, in infarction, is convex upward. Because if I start talking on that, then it will take more time, and then we will just lost. So QT interval, about the QT interval is just from start of QRS complex to end of T wave. And this is a normal QT interval, like 350 to 450 milliseconds. In other words, you can say about 2 large boxes. One large box is equal to 200 milliseconds. So 2 large boxes would be around 400. And some people say it's a quick method that you have to say T wave. If T wave is broad, like if T wave is more than half of the RR interval, then you could say, not accurately, but you can say as a quick, you can say it's long QT interval. Again, there's a lot of, if the heart rate is 60, then obviously you can calculate with these. If the heart rate goes slow or fast, then you have to get it corrected by different formulas. So common is Bayesian, and again, these formulas are available on the iPhone, on the, on the calculators as well. You can get downloaded, applications. But at least you should know if it's more than 2 boxes, the heart rate is about 60 or 70, then it's significant. If its heart rate goes 100, but then obviously less than 2 boxes could be long QT interval as well. It depends upon the heart rate. So again, it might be a little bit complex for this talk. I will just talk about later on. And obviously I thought might be more interesting if I tell you about the causes of QT. At least you can identify if the patient is taking antipsychotic, because lots of antidepressant, because most of the GPs I think used to give antidepressant as well. It's very important if the patient is having these. Or antibiotic, erythromycin, macrolide, clarithromycin, amiodarone, one of the cardiac medication, which if I have started and patient is having a collapse or some symptom, then you should be worried about QT interval.
Erythromycin.
Right.
Macrolide.
मैक्रोलाइड क्लिथ्रोमाइसिन भी
उससे जो
there's a lot of
macrolide group से related जो medicine है like erythromycin.
वो भी है, वो भी सारे आई जस्ट पुट ऑन सारे आ जाए मैक्रोलाइड सारे मैं उसमें ना
ये macrolide.
हाँ सॉरी बस जस्ट क्योंकि इट्स क्वाइट कॉमन दैट्स द रीजन मैक्रोलाइड्स जस्ट सारे मैक्रोलाइड्स just to say or there's a long list about more than 100 medication which can cause acute. I don't want to confuse but to know about some antidepressants, some antihistamines, some antibiotics like macrolides and some cardiac antiarrhythmic medication like codron, codeine. These can cause that as well. So phenytoin and all this stuff you should know about that. Other is these metabolic problems, like especially in ICU or hospital setting, hypothermia, hypokalemia, hypocalcemia, hypothyroidism. And obviously, of course, long QT interval, congenital form, Brugada syndrome, these one. And other important thing is that sometime in myocardial infarction, after myocardial infarction, you can get the long QT or myocarditis as well. So that's the reason patients should stay in the hospital for a day or two. And after that, if they have any problem, that's the reason we just say, let your GP know about that. T wave, again, I already told you if it's a tall or something is indicate about the ischemia and other things. T. So I will go through quickly because we have spent a lot of time. How much time we have spent so far? Kitna time ho gaya hame? More than? How?
It's about 50 minutes.
Oh, I'm sorry. Do you want me just to go through this quickly 5 because these are very interesting. I took you more time, but obviously I thought because you were showing a lot of interest, you were asking a lot of questions rather than just I'm speaking and you are listening. So let me tell, these are the 5 we will go through quickly. If you want to stop, it's up to you. You can stop here. There are 5 questions. It's very important. Yeah. So obviously we talk about 10 patterns and all the history is there. This is a 25-year-old gentleman who has had a collapse while playing a cricket match. He has a previous history of fall or syncope as well. Now this is the ECG and have a look on the ECG and go through this scheme which we have already discussed. Rate, rhythm, axis. पहले तो ना बता दें आप नहीं go through one by one. I would say P wave नहीं. Okay, sir. Rate. Should we go through the rate, please?
Rate irregular.
नहीं irregular इसलिए लग रहा होगा क्योंकि QRS complex क्योंकि इसमें rhythm lead नहीं है. QRS complexes are up and down. These are due to the leads, but I think interval is same. I think so. I can give you a clue because there is no rhythm lead, but yeah.
तकरीबन 5 पेयर.
Right. So 5 mean 60. That's good. And the other method, my favorite method. This is a 10 seconds. This is a 10 seconds. So how many complexes are there? That's 60. So that is easy as well. Like for the atrial fibrillation, what I'm saying. Yeah. So rate we have the rhythm. Can we see any P wave or not? There's something here, but this is not normal, isn't it? There's something either it's a P wave or whatever it is, but it's not normal. Something is going on here. Okay. Axis. Can we tell about the axis? We can come back to the rhythm again. Axis. So it's a lead 1. And where's the lead? Yeah, left axis deficit. That's good. Well done. And PR and P wave. Can we see any P wave and PR interval? Yeah, P wave, you can say it might be this is P wave. This is P wave, but PR interval is very short, isn't it? It's less than 3 small boxes, isn't it? So this is very short, and you can see there is a slurring here. So I think few person already identified this is a delta wave. Sorry, this is a delta wave, and this is WPW syndrome. Okay, so T wave, ST is normal. We can go through there. Okay, so we already, I think all of us identified the heart rate by 2 methods. One is the box method, other is the strip method. Rhythm we said is regular. Left axis very well picked up by all of the short PR intervals, slurred upstroke QRS complex, you can see here, and normal. So this is a WPW syndrome. It's very important. As I said, This is due to the accessory pathway which connect from atrium to ventricle. It's not goes through the AV node. Remember, AV node is a speed breaker. If you lose AV node, then if patient at any time, like in old age or sometime, if you get atrial fibrillation or atrial flutter, which you can get from any sepsis, respiratory diseases, chest infection, then they can degenerate into ventricular fibrillation. So if you find out WPW syndrome, it's like an emergency, should send to the electrophysiologist and should be ablated. Because you never know, the patient could get, like, if it's running very fast, 180 or something, or if something happens like atrial fibrillation, it will degenerate into that. So it's very important to ablate this WPW syndrome. So this WPW. So these are the thing next. This is a 31-year-old gentleman who came to the medical insurance for medical checkup, and ECG was done as a routine. Otherwise, he's fit and well.
उसका 60 है
जी about 100 या अच्छा बॉक्स मेथड कर लेते हैं
3 boxes है
नहीं
अच्छा
100 हो गया ये डिवाइड करें
1 2 3 नहीं 3 से कम है ना और 3 से ज़्यादा है सॉरी ऑब्वियसली 3.4 कह लें 3.2 कह लें 3 से थोड़ा ज़्यादा तो इसका मतलब 100 से थोड़ा सा कम हो ये थोड़ा सा चल लेकिन ये वाला मेथड करें ना आप
मेरा तो फेवरेट 300 वाला
नहीं आप ये वाला तो करें ना ये भी आसान जल्दी से 13 ठीक वैसे ये वाला नहीं है इसको अच्छा 1 2 3 4 5 6 7 8 9 10 11 12 13 14 चले 14 हो गए 14 मल्टीप्लाइड बाय 6 हाउ मच नहीं बाय 6 84 सो हार्ट रेट इज 84 ओके चलें बाकी रिदम देख लेते हैं नॉर्मल ठीक है जी बिल्कुल नॉर्मल नेक्स्ट एक्सेस देखें एक्सेस भी नॉर्मल है गुड पी आर इंटरवल पी वेव्स आ रही हैं और मेरे ख्याल में इसका ठीक है मोर देन 1 बिग बॉक्स नहीं है और स्मॉल भी नहीं है तो इट्स फाइन अगर आप गौर करें तो ये ठीक है क्यूआरएस कम्प्लेक्स ठीक है एसटी टी वेव्स इस नॉर्मल क्यूटी भी अगर शॉर्टली क्यूटी देखें मैंने आपको बताया था कि हार्ट रेट 2 बिग बॉक्सेस से कम ही है ना ठीक है ना क्यूटी भी ठीक है इसका सो नॉर्मल ईसीजी यस नॉर्मल ईसीजी अब देखिए हिस्ट्री एंड एज एंड सब तो हर चीज़ बता रही है इट्स नॉर्मल हिस्ट्री दैट्स द रीजन रूटीन चेकअप इसलिए मैंने बताया इट्स वेरी इंपॉर्टेंट यू शुड नो अबाउट
मुझे कंफ्यूज करती है डिफ्लेक्शन जो है
नहीं डिफ्लेक्शन आप इस पर कंफ्यूज ना करें डिफ्लेक्शन तो ये देखें ना डिफरेंट लीड्स की वजह से है लीड्स डिफरेंट जगहों पे पड़ी है और डिफरेंट तरीके से देख रहे हैं कोई इधर से देख रहा है कोई इधर से देख रही है लीड तो साथ में वो कम्प्लेक्सेस तो उसी लिहाज से ना आपको मैंने वो ज़रा कार्टून एक दिखाया था कि लीड इस तरह पड़ी है कि जहाँ हार्ट पड़ेगा तो डिफरेंट व्यूज़ आ रहे हैं तो इसलिए हो रहा है क्योंकि हमारे पास रिदम लीड होती है तो उसमें एक जैसे आते कम्प्लेक्स ये तो हमारी चेस्ट लीड्स है ना ये सारी लीड्स हैं जो रूटीन में हमारी ईसीजी होती है उसमें एक्स्ट्रा चीज़ ये होती है कि ऑब्वियसली यू गेट हेयर द रिदम लीड जो इधर थोड़ा सा मिसिंग है रूटीन जो स्टैंडर्ड हमारी ईसीजीज है ना सो एवरीथिंग इज़ ओके ठीक है इसमें ऑब्वियसली हिस्ट्री टेल्स यू दैट दिस पेशेंट वुड हैव अ नॉर्मल ईसीजी ठीक है चलें नेक्स्ट थर्ड में हम क्विकली करते हैं बस 5 में टोटल ये थर्ड वन है स्टॉप कर दें इधर नहीं आई एम सॉरी जी मैं थोड़ा गया था थैंक यू चल नो इट्स फाइन मीन जस्ट राइट नो आई एम फ्रेश इट्स फाइन स्कीमिया ठीक है जी इसमें हार्ट रेट 130 है स्कीमिया आपने पिकअप कर लिया ठीक है ना स्कीमिया ऊपर हिस्ट्री भी आपको ऑब्वियसली पेशेंट कम विद द चेस्ट पेन ऑल दिस स्टफ इज जस्ट रेडिएटिंग टू लेफ्ट आर्म ठीक है और एज भी ऐसी है कि जिसमें आपको मायोकार्डियल इन्फार्क्शन या इस नॉन स्टेमी स्कीमिया है, नॉन स्टेमी इसको चल रही है, ठीक है। ऑनगोइंग पेन,
सेगमेंट डिप्रेशन
जी जी, एसटी सेगमेंट डिप्रेशन, ठीक है। इन्फोलेटरल लीड्स में ना, ठीक है। हार्ट रेट भी आप अगर पूरा करें,
सर पहले एलिवेशन उसकी हुई है फिर डिप्रेशन हुई है।
नहीं डिप्रेशन ही है, फर्स्ट डिप्रेशन होते हैं।
फॉर्चून जब हुआ है
नहीं इसको अभी
सेगमेंट जो है
शुरू में डिप्रेस ही होते हैं, अगर ये ऑनगोइंग चलता रहे तो बाद में हो सकता है। हाँ। और इट डिपेंड्स कि अगर आर्टरी बिल्कुल ब्लॉक होगी ना तो फिर ऊपर जाएंगे। इसका मतलब आर्टरी बिल्कुल नैरो, लाइक 95% ब्लॉक हुई हुई है, 5% जो एरिया है उसमें से ब्लड जा रहा है। जी इस्कीमिक, जी इन्फ्लेटर, नॉन स्टेमी है ये, नॉन एसटी एलिवेशन हम है। ऑनगोइंग पेन है, लेकिन ये हाई रिस्क होते हैं जो ऑनगोइंग पेन के साथ फ़ौरन इनको हॉस्पिटल में जाना चाहिए। सीसीयू में अगर ऑनगोइंग चलता रहे तो फिर इसको डायरेक्टली हम कैथ लैब में ही जा सकते हैं, रेस्क्यू कर सकते हैं इसको, ठीक है। चलें, 72 ईयर ओल्ड लेडी हु प्रेजेंटेड विद द हिस्ट्री ऑफ सिनकपी और कोलैप्स, ठीक है। तो ये उनकी ECG है जी। अगर ये इसको जल्दी से देख लें, हार्ट रेट इंपॉर्टेंट है इसमें, अगर आप मुझे बता दें। जी वेल डन, 6 हैं तो हाँ 1 2 3 4 5 6 7 8 9 10 1 2 3 4 5 6 7 8 8 मल्टीप्लाइड बाय 6 48 50, बिल्कुल ठीक है। 50 हार्ट रेट है। रिदम देखेंगे जल्दी से, रेगुलर है। एक्सेस अगर देख लें 1 नॉर्मल है, ठीक है। पी वेव वगैरह नॉर्मल है सारा कुछ, हाँ साइनस ब्रैडिकार्डिया। बट दिस पेशेंट इज कमिंग विद अ कोलैप्स, यू शुड डू लाइक एको एंड अदर थिंग इज वेरी इंपॉर्टेंट, होल्टर मॉनिटरिंग या कुछ और। अगर ये ड्रग नहीं ले रहा बीटा ब्लॉकर, तो क्योंकि इसकी एज 72 है, इट्स वेरी इंपॉर्टेंट। ये 72 पर पेशेंट या तो वेजोवेगल हो सकता है, हमें आइडेंटिफाई करना चाहिए। इट वुड बी हाई रिस्क, लेकिन साइनस ब्रैडिकार्डिया ओनली ऑन दिस ECG, ठीक है। चलें, द लास्ट वन, दिस इज अ 40-year-old gentleman who came with the emergency department, lady, sorry। ठीक है। व्हाट अबाउट, जी बहुत ज़्यादा फास्ट है। हार्ट रेट कितना होगा रफली? जी
150 है
जी 150, मोर देन 150। 2 स्क्वायर से भी थोड़ा सा कम है, ये देखें ना, 2 स्क्वायर से थोड़ा सा कम है, थोड़ा सा बढ़ा देते हैं हम। हाँ, अगर मैं आपको बताऊं ये कॉम्प्लेक्सेस 28 हैं, तो कितने कहेंगे? 28 कॉम्प्लेक्सेस को मल्टीप्लाई करें से मैथमेटिक्स 1 जी, हाँ जी चले। वेल डन, ये देखिए ना, हम ये देखिए स्लाइड डिप्रेशन आर देयर, हाँ ठीक है। ये सारी ECG इस तरह, अगर मैं वही कह रहा हूँ कि ऑब्वियसली इफ यू गो थ्रू द रेट रिदम, जी बिल्कुल, आई वाज टेलिंग यू दैट ऑब्वियसली ऑलवेज एसटी डिप्रेशन ड्यू टू इस्कीमिया, बट इट्स रेट रिलेटेड, इट कुड बी रेट रिलेटेड बिकॉज दिस इज अ यंग लेडी, ठीक है ना। तो ये हम कभी कभी वर्ड यूज़ करते हैं कार्डियोलॉजिस्ट या बाकी भी लोग, रे रिलेटेड इस्कीमिया है, रे रिलेटेड एसटी डिप्रेशन है, तो ये वो हो सकता है। इसका ज़रूरी नहीं है कि हम इसकी एनजीओ करें, कुछ करें, डिपेंड बन। एक्सेस आप बताएं ना, ये देखिए, अच्छा सॉरी, नहीं देखिए ना आप, एक्सेस आपने किस में देखना है? इसमें देखना है और 1 में, जिस यस सॉरी, इट्स माय मिस्टेक, इस लेफ्ट एक्सेस। थैंक यू जी, थैंक्स अ लॉट, मैंने जल्दी में ज़रा कर दिया, ठीक है। ये लेफ्ट एक्सेस डेविएशन, वेल डन, वेल यू पिक्ड वेरी वेल, ठीक है। तो आपने इस तरह ECG को प्रेजेंट जब भी देखना है, उसका रेट, रिदम, एक्सेस, और मैंने आपको बताया इट्स वेरी इंपॉर्टेंट, हिस्ट्री अबाउट द पेशेंट, एज एंड ऑल दिस स्टफ। जैसे अब वो यंग पेशेंट था, मेडिकल इंश्योरेंस के लिए आया है और सारा कुछ उसकी ECG कर रहे हैं। अगर मैं वैसे किसी हाउस विजिट को भेज दूँ, वो पैनिक हो जाएगा, उसे ये बताऊँ कि भाई इस तरह है, तो वो थोड़ा कूल डाउन हो जाएगा, लगता है एबनॉर्मेलिटी नहीं है, एक कॉन्फिडेंस बिल्ड हो जाता है। ऐसे पेशेंट में आप देखें, ठीक है। चलो, थैंक यू वेरी मच, थैंक्स फॉर